So, burnout is distinct from depression, anxiety, and general malaise.
Right.
Burnout is actually in the clinical context, in your work context, you feel detached, you feel cynical, you feel exhausted. You think that whatever you do, nothing matters. So, being a consultant, you are not just a doctor who look after patients. You have to be a leader for their entire area.
Okay.
And then work with the politicians, work with the commissioners, work with the local communities, work with the other disciplines within the medical fraternity to see that the outcome that we want is reached. So a society that is based on competition, you have to win over others, is going to have its toll on human beings because it's against our nature.
Hi, welcome to another episode of MedVentures. Today, our guest is a consultant psychiatrist working at UK. He also has an institute of his own at Thrissur, which is called In Mind. Today, we will be mainly discussing about a very important topic, which is mental health, which is spoken about for people like celebrities, common people having a lot of problems in this current era. But today, our main focus is on mental health among doctors. So I welcome Dr. Manoj Kumar to our show. Welcome.
Thank you. Thank you. Nice to be here. Yeah, good to be here.
So, can we have a small, brief introduction on why you chose to become a psychiatrist and what do you currently see the role of mental health in general society?
That's a big question.
Right.
That's a really big question because you're asking me why I chose this specialty. I was born and brought up in Ponnani, which is a coastal village in Malappuram district in Kerala. And one of my earliest one of the memory is about a 7-foot man who speaks only Hindi,
Right.
and who is naked and who walks in Ponnani streets up and down. And he would go to all the shops and just ask him for two things. One is red chili and onion. And this is one of my earliest, kind of introduction to abnormal behavior. And he never has actually caused any trouble there. And the society, in a way, accepted his presence. And looking back, I have thought this kind of question, or why I have chosen mental health as my specialty. I think it starts from there. I was intrigued by his presence.
You were always a very curious.
I was curious about why this Hindi speaking man who is naked and who is actually asking for things that we don't do,
Right.
and then why our society has kept a very positive frame of mind about him, allowing him to exist in that village.
Right.
And I think that was a kind of starting point where I started to think about mind and mental well-being.
Okay.
And incidentally, there was when I was in my high school, I used to visit a library, and which is known as Idasheri Smaraka Mandiram. And once I came across a book, which was Interpretation of Dreams. I took that book because it looked very big.
Okay.
I wanted to read big books.
Right.
I never read that. I tried a few pages. I didn't understand anything at all, and it remained in my bedroom as my pillow for a long time. But later on, and I could see that my act of taking that book was, in fact, me trying to understand, and I was curious about how human mind works.
So, whenever you started inculcating the choice of become a psychiatrist, our general society, when you choose to become a doctor, you're always spoken or given a choice of becoming a physician, becoming a surgeon, becoming a cardiologist. Is there anything, any mentor, any specific person who guided you to choose psychiatry as a profession?
There were several individuals who liked the person I said,
Right.
and people I have come across in the wards. And I was very much interested in how, in the large scheme of things, how do people get ill and what keeps them ill. I was interested in the social pathology. And part of the social pathology is always the behavior, lifestyle, and the personal view of life. Right. So early on in the medical career, I started to think about, how do people become physically ill and what is the role of their mind in it. And now we know that every physical disorder that you take, you can show that mental process is a key factor in the biology of physical illness. We used to think about physical illness leading to mental illness or mental health problems. Now we are more and more understanding that not only mind influences body, not only body influences mind, they work together. They are one and the same. Okay. And that kind of an understanding was the main kind of driver in the medical school time. And later on, when I went to UK, I did my master's in public health because that was still another area where I was interested. Still continuing interest in public mental health.
Was there any, negativity from your family on choosing such a profession?
Not from my family. Not
Okay.
from my family. Not at all. And they were my parents and my brothers and sisters. They didn't actually put any kind of discussion around which specialty you go or which kind of path you take. So I have to say that I had a free run on
Okay.
making those kind of decisions.
So finally, you are happy that you have.
Definitely. If I have another chance, I would definitely want to start this much earlier.
Okay. So now you have finally chosen to become a psychiatrist, and we know within our society, a lot of people are suffering from mental health issues, and it is a very common thing to listen right now about mental health issues. But what we want to discuss on our podcast is mainly about our medical fraternity. How much are they suffering from mental health? So, can you give us an idea on the prevalence of mental health issues among our doctors and nurses?
Okay, that's very important starting point when we look at the large landscape of doctors and their well-being. One of the things that I remember now is around 48% of doctors worldwide, that is from the WHO studies, stating that they are facing burnout. So burnout is distinct from depression, anxiety, and general malaise.
Right.
Burnout is actually in the clinical context, in your work context, you feel detached, you feel cynical, you feel exhausted. You think that whatever you do, nothing matters. That is a paralysis state for a doctor. And I do believe that doctors work better when they have the curiosity with the patient's problems, when they are open minded, and when they actually are present live, they do the best.
Right.
But burnout means doctors are getting more and more detached. It just becomes a task for them to do. And this is leading to negative effect, not for themselves. Their family life is affecting, their physical health is affecting, their mental health is affecting. It also affects their clinical performance. So there is risk to patients as well as risk to their own, friends, family, etc. One study shows that doctors who actually are in that phase of burnout have more cardiovascular problems, more physical health problems, and they die early. So burnout is a serious problem for doctors. Having said that, when you come to mental illness or diagnosable mental illness,
Right.
which is a different kind of a question,
Okay.
you know that after the COVID pandemic, the number one disorder among this group is PTSD, that is post-traumatic stress disorder.
Okay.
And depression and anxiety are also very common among doctors. Then the next question is it just after the COVID pandemic? Of course, there is the idea of moral injury. Doctors
Idea of?
face the moral injury.
Okay.
That means You as a trained clinician is feeling helpless. There is a moral dilemma. When you have only one ICU bed, whom do you allocate that? And it is up to you to make that decision between life and death. And then you feel that you failed the other person. And doctors has gone through moral injury, during the COVID, like anything in Europe. So that might be one reason why there is an escalation in mental health problems post COVID among doctors, nurses, and all healthcare workers. But even prior to that, doctors seems to have higher mental health problems than general population. But this is based on surveys. Then you look at, is it only doctors who has more mental health problems? You compare with other occupational groups. An interesting finding is all occupational groups has higher mental health problems than general population. This is surprising in this because you will expect less mental health problems in affluent, educated, reasonably stable kind of strata like doctors. Then one would conclude that it might be because surveys are not really indicating the prevalence, especially in mental health, because you are asking questions, you fill a questionnaire, and generally literature would say that, of course, there is a significant proportion of doctors who are struggling with mental health, but it might be similar to some other professions, but it might also be a reflection of their general dissatisfaction and burnout. Right. So we can conclude that it is a big problem. It is a big problem. Burnout is a much bigger problem. In Kerala, when I meet my friends, I see the cynicism. I see the detachment. I see that they always say that, oh, don't think about any policy, don't try to change the policy, nothing will work. There is an apathy, and this is a significant kind of a problem. And when there is a larger landscape of apathetic people who believes that nothing will change, the optimism is gone, that seeps down into the individual. Right. And that individual, when they are in crisis, they already have a landscape where everything is kind of hopeless. And their personal life events becomes much more a serious kind of a loss for them. And you can see that trajectory in how people perhaps land in serious depression or sometimes suicidal thoughts.
What do you feel could be one of the few stressors people go through to get such an early burnout?
There are various factors for burnout. One is the landscape of medicine is changing. You used to have lots of autonomy and control.
Control.
You were master of your own skill.
Right.
Now you are part of a larger cogwheel. You are just a part of a larger system, especially in corporate hospitals. You might feel that you are being, kind of just being a small part in a large scheme of things. And you may not have full clinical autonomy now. If you're working in an insurance kind of a setting, the insurance dictates what kind of therapy you give. Right. In America, my friends say that, previously there will be, based on the clinical need, you will say that, okay, you need to have 20 sessions of perhaps CBT. But the insurance will just say that, no, hang on, you can give only 6. So your autonomy, clinical decision making is affected by the larger picture. In state health service as well, these kind of things play in a different way. So I think doctors are in some sense losing the autonomy and the control they had in their lives. This is, you can relate this to the famous Whitehall study. Whitehall is a small village in London, and Whitehall study started in 1960s. And they looked at how people become ill and what are the social factors. And they studied how social hierarchy in an organization decides people's longevity. Okay. So what they found was, if you are doing a job that is, you have no control over it, you are likely to die much earlier. Your cardiac health is going to be extremely poor, you will die early. This is after adjusting for all confounding factors like smoking, lifestyle choices, obesity, everything. Right. And the single factor that makes difference is on the strata of, where you are in terms of control over your work. So if doctors are losing the autonomy, the control in decision making, they are likely to have physical health problems through inflammation, through cardiac changes, and through stress. So that is just one kind of how the social condition changes the biology and lead to illness. So that is Whitehall has taught the world.
Right.
If the employment conditions are changing, that might be a significant factor.
Does financial instability add on to burnout?
Early in the career, now if you look at Europe, previously education used to be free, including university education. Now, with the huge amounts of loan, because they have to pay for the tuition fee, which was free previously.
Right.
So the world has changed. The relationship has changed. So they definitely have to worry about their income. And especially in the early stages of medical career, you know that you have to spend loads of years, much more than any other profession, to reach a stable kind of a professional status and income level. So definitely that might also be contributing to problems, mental health problems among doctors.
As a young medical professional, our main concern is to establish a stable practice at the earliest. And when we are unable to do it at an expected pace of time, we tend to get worried fast. We tend to get irritated fast because we always compare ourselves with our peers. We have so much digital information, or we see that our peers are doing better than us. Do you feel that comparing ourselves with our peers can also lead to an early burnout?
Human beings always compare with fellow beings because that is how our brain is wired.
Right.
We are social animals. We always look for threat from outside. We always look for cooperation from others. So, and we also look at where we are on the ladder. So that's an important part of how our brain works. So early in the career, if you are uncertain about your own future, your position within the hierarchy, and that can really activate your stress response systems. And when the stress response system is activated, we know that now if you measure the basic base level of amygdala activity, brain structure,
activity.
if you measure the amygdala's basic base level activity, you can predict cardiovascular events. So amygdala is the center of our threat activation system. So if you are exposed to different kinds of social stresses, threats mainly, your amygdala activity will be high, and that will predict that you might have more cardiovascular ill health in the future. So that is another route to think about, especially in the early career, doctors.
How do we document amygdala activity?
There are neural investigations which
Nice.
you can functional MRI and combine that with the quantitative EEG. You can measure that. And recently, Lancet did publish a beautiful paper on that, how amygdala activity will predict the cardiac events.
So you've been shuttling around UK and Kerala for your work. What is the approach of work pattern, or there's something called as work-life balance, which is very different in Kerala or in India particularly compared to the UK? Are there any ways, or what do you suggest about your opinion on a right work-life balance?
One thing I notice is here, when I work here, you are a doctor 24 hours. You are a doctor on a Sunday, you are a doctor during the midnight. There is the social identity is fixed. And the script given to you is the same. You are a doctor, you have to look after others. But in UK, you will see that you are just like any other worker. And at 5 o'clock, when your duty finish, you are no more a doctor. So what I'm saying is there is much more kind of the social identity is work identity here.
Right.
In there, you see that differently. So that is a space where you can actually engage with other people just like any other people. So that's one important, social kind of a, difference between these two systems. Second is doctors and nurses are the most trusted professions in UK. Most trusted professions. See, I mentioned about the threat system.
Right.
And in India, particularly at this, in the last decade or so, you see that doctors are not feeling safe. Doctors feel that they are not being trusted. There are reasons for that. So in a society where doctors are seen as the most trusted people, that makes a big change in the way you feel about yourself,
Right.
and the way you conduct your day-to-day life. And NHS, National Health Service, is provided by taxpayer. Every care is provided according to the clinical need,
Right.
not based on how much you can pay.
Right.
So there are no moral dilemmas in that. But the other dilemma would be the services is provided to everybody, so there could be a long waiting list. It will be given based on the need, but there could be a waiting list. So the services will be trying hard to cater to the community's needs. So being a consultant, you are not just a doctor who look after patients. You have to be a leader for their entire area.
Okay.
And then work with the politicians, work with the commissioners, work with the local communities, work with the other disciplines within the medical fraternity to see that the outcome that we want is reached.
Right.
So there is much a broader kind of a work. And because of that, doctors would have different kinds of training as well. You will be an advocate for patients.
Right.
You will be a researcher. You will be a teacher. So the work is more interesting. And another difference is here you will see that in medical schools, there is no distinction between clinical team and academic team. There's no distinction.
Right.
But there, if you are everybody is doing research. All consultants are active in some sort of audit or research or training and teaching. Everybody is involved. Not here, it is just in medical schools. So the difference is, if a private practitioner here, I'm a great advocate of primary care physicians here who are actually looking after families to be a big part of medical education.
Okay.
They should be. So in UK, you will always be involved in teaching, research, and advocacy, etc. So life is much more, in that sense, more interesting. It is not just the clinical work. And people tend to think that, okay, in UK, in your clinic, you might be seeing less number of patients, but it is compensated by the accountability.
Right.
The accountability as well as the leadership role, managerial role, teaching role, and all other roles, you become really, really busy. So the work is much more interesting in that sense. The other thing is NHS is always changing. If any incident happens in anywhere in the NHS, immediately the nationwide a change will come.
I see.
And that will happen within days. If a practice, for example, we used to have the problem of patients discharged from psychiatric facilities dying by suicide within the 7 days. There is a peak.
Okay.
Post-discharge, there is a small peak in suicide. So immediately once you get the data, the nationwide, there's a change. Within 7 days, you have to see the patient face-to-face after discharge. That's a must.
Okay.
Then it became 48 hours. So there are numerous examples for how the system is sensitive to ground realities.
Right.
So that is not the case here. And the other difference is, here I see that in a big employer, a big hospital, doctors are left to themselves for caring for themselves. But there will be annual appraisal, you will have mentors, you will have reflection groups, you will have supervision groups, and there is a hell lot of support system for consultants and junior doctors and others. So there is much more, caring in that sense. There are structures and institutions for that. And UK also have, for doctors, there is a separate kind of a stream of care where doctors will be even admitted to doctors only kind of unit,
Right.
Nationwide. So there are lots of emphasis on doctors' well-being within each organization. There will be well-being champions. Some, they would be, looking after how the doctors are doing,
Right.
to support their emotional and well-being needs.
Why can't we incorporate these kind of systems within our country?
We have been suggesting this.
Okay.
With Indian medical organizations, we have been, requesting them to think about, bringing in well-being champions. Each hospital has to have a well-being champion who talks about emotional issues, who openly talks about difficulties, and who organize the reflection groups,
Right.
who does staff surveys, anonymous staff surveys. See, anonymous staff survey is a very good indicator of the emotional health of the employees of the organization. And in UK, because we are all trainers, we train junior doctors. Nationwide, the medical council will do every year a survey among trainees.
Okay.
And you will be benchmarked against the nation.
Okay.
So if your unit, your trainees has marked you down, and there will be an investigation asking questions. Is there anything that we could do to change that? So there is always that loop is working, audit as well as what to do. So I think they have a system which I call as organizations with memory, organization which is open, and organization which is ready to change. But here it is much more difficult to bring in changes.
As once we attain a title of being a doctor or being a nurse, we've always been projected to someone who will always be mentally and physically healthy. That's what the public thinks about us. But lately, we have seen or heard a lot of doctors considering episodes of suicide, depression, anxiety. But as doctors, we always have that stigma. If I approach someone, what will the public think of me? Or how will I face the public? So, what should doctors do at such a moment? How can they seek help?
This is a really difficult problem. Doctors are poor in managing their own health, physical health and mental health.
Right.
So we need to think about what is the inner kind of script that doctors have. And there seems to be in a state where they they are in a state of denial.
Right.
When they really face a problem. They seem to be thinking that they are omnipotent. So that might be coming from the training where they are actually promoted to follow a brave and bold model.
Right.
If you look back at our training within the wards, your professors, your seniors, even other professionals would make fun of somebody who, when they are faced with a challenging kind of a situation or a death or a extremely painful or a difficult situation, if they show any emotion, that is considered to be, he's not fit to be here kind of thing. So generally we promote that kind of a model, which is brave and bold, means good. Actually, we are denying, or we are actually refusing to accept the fragility that we all share.
Right.
We are all fragile. And unless we accept that and assimilate that fragility as a source of our strength, we are not going to change our inner view of ourselves. Okay. So doctors have that inner script, which is, of course, borrowed from outside world. In Malayalam, there is a phrase, kurundotikkum vadam. That means there is an underlying belief that a physician should never get ill.
Right.
But as you said, we see that quite often in all the studies that physician health is getting poorer and poorer.
So, how does one seek help if a doctor at present, today, is currently in India, is currently having a problem? Who does he see first? And does he go to a particular organization? Do we have an organization in India, particularly for doctors?
If you look at the more difficult mental health problems like suicidal crisis, 50% of suicide occur, completed suicide. People complete their suicide in the first attempt. So there is not much actually chance for follow-up.
Right.
50% die in their first attempt. And in Kerala, there has been recent media reports of people in different age groups, doctors dying by suicide. So we lose these people in their first attempt, and they all leave some signals to their family and friends, not to healthcare organization, not to their practitioner clinicians. They leave these signals within their closed community of friends and family. So unless there is a kind of a public preparedness to read the signals of distress in fellow human beings as a general skill, we are not going to make any inroads into that kind of outcome, including among doctors. Of course, if there is within the professional group, if I am watching somebody in my group, in my professional group, a person who walks fast is now walking slowly. A person who walks with his head high is walking, looking down. A person who comes to the ward saying hello to everybody, now not so enthusiastic. A person who is very mild mannered or very sympathetic with patients and compassionate with patients is getting easily irritated with patients, or somebody is making mistakes, or somebody is avoiding meetings, or somebody is not speaking in the small gatherings, then it should raise the concern, what is happening to this person? Here is the issue of emotional intelligence comes. I do feel that doctors perhaps might be lacking in emotional intelligence. Ideally, I would have imagined that through the training, through the exposure to human dilemmas and pain, their emotional intelligence would be better. But if you look back at this doctor's training and how they come to this profession, they come to this profession mainly because they are good in cognitive abilities.
Right.
And unlike in Europe, when you want to become a medical, you want to enter into medical school, you have to do some work experience in hospitals where you see all kinds of pain, all kinds of dilemmas, all kinds of skills that you need. But here it is just based on your scores.
Right.
So we are selecting a skewed kind of a population who might be lacking, especially in this world where everything is competition. People, the youngsters don't have enough time to practice emotional intelligence in
Right.
various ways.
Right.
And they lack that kind of an ability. This is what I call they are single cell organisms, that they have only this cognitive kind of abilities mainly, not all, I have to say not all.
Right.
But that is something that we need to think about. And once they get into medicine, the training is also like that. What I call what I mentioned, what I would call is anesthetize you. You lose touch with your emotions. So lack of emotional awareness, lack of emotional intelligence might be a big factor in not realizing that they are under stress, not realizing that they are, their inner self is changing, and not seeking help as well. Another factor is here the doctor-patient relationship. We need to think about how that is. If I am becoming a patient, I would want to work with somebody who is considering me as an equal.
Right.
I am an expert on my problems. So the patient is the expert on his problems or her problems. And we don't have that kind of a level playing field. So doctors doesn't want to be the patient because they are internally aware that being a patient means a unhappy kind of a experience. Not just because of the problem, but because of the way that problem is being, held. There is a sunrise as well as sunset, light and darkness. And each moment we are living as well as we are dying.
Right.
Each moment. And our life is the joining point of these opposing kind of forces. So if in our generation, we are always looking to think about the happiness only, we are on a hedonic treadmill. And we are not realizing that that is not a grounded life. That is not the meaningfully connected, authentic life. And that life is a mix of both. And as children, they are given the idea that you have to excel. And the love given is not unconditional. Love given is conditional. You are worth if you do excel in your studies. You are worth if you are good in your sports. Otherwise, what is the outcome? You are not worth it. Yeah. So these girls and boys, they want to achieve because that is the only way they can get the appreciation from others. That is where the source of their self-esteem. And these doctors or healthcare professionals or any professionals, when they face a challenge, they are not used to these kind of failures. And they feel that they are not needed by the world. They are not loved by anybody. And there is no point in living. So we have to start
Ground level.
from the ground level, from the family level. And of course, when selecting medical students, I strongly believe that each medical student who is being selected should have an exposure for at least a month into difficult kind of human life and death and illness. They should have that experience. Then they have first-hand experience of seeing things. At least they could know that this is not my field, because we don't need doctors who are not compassionate coming into this field and later they themselves suffer because they are likely to undergo burnout easily. So that is one area. Second would be to incorporate this into the curriculum. There is no point in adding more and more lectures. What I do is experiential workshops. I've been doing experiential workshops in many medical schools in India. When I come, 2 days of experiential workshop. In this experiential workshop, what we do is look at who we are. Where is our strength coming from? What is authentic happiness? And how do you soothe your brain? And how do you see the balance? And these are the things that our medical students has to get experience in, and that you cannot impart through a lecture. You have to practice it. You have to experience it, and that is the way to transform your inside.
So as we understand that, at everything needs to start working at a ground level. Whenever a child is born, the parents already have a certain profession kept in mind. They would want their child either to be a doctor, an engineer. They start saving, they start investing in certain things to have a bright educational career for their child. So, as you rightly mentioned, that a child is slowly told, unless you achieve this, you will get this. So, do you feel there has to be a training program for parents on not to pressurize children on their future?
Definitely, childhood seems to be the key for the future, and all parents want the best for their children. But I do believe that most parents are abusing the children, not in the usual sense of abuse.
Right.
When I say abuse, we conducted the largest study in India here in Thrissur about how children at home and at school feel that they are abused physically, emotionally, sexually, in all sense of the definition of abuse. And majority of children report that they felt abused in different ways. So that is the background of research and data. But most parents have a script in their mind, as you said, what the child need to be, what is success. And they always practice this idea of giving rewards, right, for achievement, giving love for achievements. And what it leaves is actually, especially in the world where competition is everything, which I believe is against the innate nature of human beings. I believe that, and there is enough research to support the notion that we are cooperative animals. Because a human baby, among all the animal species, has the one of the longest time it takes to become an adult. If you look at a horse, it walks immediately. It can defend within weeks. But a human baby, it takes long years. And this brain change, the changing brain and the developing mind and body, long years need cooperation from everybody around. So innately, we are wired for cooperation. So a society that is based on competition, you have to win over others, is going to have its toll on human beings because it's against our nature.
Right.
So that's the first thing to remember. And parents, by their without knowing actually, and with being within this system, they have to act within the system. They have to be extremely bold to go out of the system to give that freedom to the children. not actually following the script of the society. These are only the jobs that are acceptable. Now, I think parents are thinking differently. They are seeing that children can flourish when they are given their free will. They need boundaries, they need guidance, but they don't need strict prescriptions. When parents become prescriptive, it is actually killing the innate ability of the person to find something that is creative, something that is innovative, something that is rejuvenating themselves. And it kills their healing power inside. These children, when they are in their adulthood, don't have an inner soothing mechanism where they feel that even if I fail in this exam, I am being loved. And this is not happening at a cognitive level. This is happening at a very innate, unconscious level, where people, when they are faced with a criticism, at job you might face a criticism. From patients, you might feel that they don't value you sometimes. You know, in all those kind of negative threat situations, a person who has been in attunement with their primary caregivers, where they have actually provided unconditional regard and unconditional love, they are more likely to be in a state to take it positively. Right. And to manage it effectively, because over the time they have learned to manage, accept, assimilate, and express different emotions. Because in many houses, negative emotions are not allowed. Right. Negative emotions are absolutely barred. They are banned for that. They are grounded for that. So you're right in saying that we need to start from the family and what is a good life, and how we can actually inculcate that kind of how we can help young minds to develop into independently healing, independently functioning, able to manage life's challenges well, and also to succeed in whatever they choose to be their profession or their career or their work.
So, do you feel that maybe training programs at schools for parents and children would be a good idea?
I think we might need to start it before that. Okay. I would start with premarital.
Premarital.
Because we have enough evidence to say that the mental state of either the mother or the father, even before the baby is born or during the early conception period, is itself is foundation stone for the future behavior and emotional well-being. And so we might need to start from there, where people think about the child and the pregnancy, and how they would want the child to be, and what kind of stress-free environment they can create. And there is a lot of research nowadays coming that the intrauterine life and the persons around and the environment around is having an impact on children's future, even including their longevity. So we need to start early. Of course, we need to find ways of how would we do that in our Anganwadis. Do we have the human resources to provide that kind of intervention? Or how do we change the social script of parenting? Right. How do we change that? How do we actually make people realize that you need to believe in this child? You don't need to, make them do things that the society at this point want them to do. So there is a need for a rethinking in how we provide that.
I've always heard this term that people are going for therapy. What does actually therapy mean and what does it consist of?
That's an interesting question.
Because
Therapies,
my concern is whether this term therapy is loosely used currently by the current generation.
okay, I do agree that it is very loosely used. But at the same time, historically, therapy meant any kind of dialogue with someone else where that dialogue leads to a change in you.
Right.
So in that sense, over the centuries, this has become more formalized. So you need to have a formal kind of training, and you will have a specific theory to work on. about the human problems, and there are different theories. From psychodynamic theories, where unconscious or childhood experience, etc., are the prime motivators for human behavior, to cognitive behaviors where therapy, where you think about here and now, what you think is what leads to your emotions. And there are other therapies which believe in primarily in emotions are the primary thing, and you need to change that. So there are different theories and theoretical approaches. So there is a formal training, there is a theory to explain the human behavior, and that leads to a change. But then what I used to explain is like, suppose you consider your mind as a house, and you want to change the paint, you want to make it look beautiful. That is what I call as counseling.
Okay.
But you want to completely, from foundation to the walls to the roof, you want to completely deconstruct it. That is therapy. So for me, therapy is something much more deeper. You are aiming
Change.
for a deeper, insightful change,
Right.
where the person reaches a stage where they are able to understand, deconstruct themselves, and to synthesis them, to put them together back, but with a new kind of an engine.
Right.
So that is therapy. And it takes long time. It's a huge commitment. And I do psychotherapy, and I don't take many patients or individuals. I don't call them patients as such, individuals for therapy, because it's a big commitment from me as well as from the person. Because therapy is about recreating a safe space.
Right.
You have to have a safe space. You have to have consistency in that space. You have to have regularity in that space. And gradually you use that space and the relationship to mirror. Therapist becomes a mirror for the person to see themselves gradually. And the therapist is just, in some therapists, you are just a fellow traveler.
Right.
And in some kind of therapists, you are a little more active. And so in some therapies, you're just an observer. So you allow the person to find themselves where they have lost in the journey, and where is the source of their pain and suffering, and how we can recreate an individual who is satisfied, who is coming to terms with the life, coming to recreate a positive kind of a life for them. So that is the therapy in a nutshell for me.
So, if a common man needs to consider therapy, does he visit a psychiatrist first or a psychologist first?
It depends on where you are.
Okay.
It can go either way. It can go to a general practitioner. In UK, the general practitioners are sometimes tuned into these kind of things. So if a patient is coming with a backache or headache, which they can't find a reason, then the doctor might think that this person might be under stress, and it has been running for many years. And then you try to understand where the origin of this pain and difficulties are. Something is happening in this person, and what is the source. And then the doctor might refer to either to a psychologist, clinical psychologist, and the clinical psychologist will use a formulation based on their training, and then they will work on that. So it can be a good route for therapy. And sometimes you need to have a psychiatrist to rule out certain things, especially in places like India, where you haven't had a good kind of a background medical history. Because the change in the mind can be due to a tumor in the brain.
Right.
Change in the brain might be due to hypothyroidism. Change in the behavior or emotions or sadness could be due to an early stage of a malignancy. We don't know those. So we might need to make sure that the person is otherwise physically healthy, and nothing physically is actually explaining the suffering, the mental suffering. So in that sense, either a good physician or a psychiatrist actually provides both, as a good physician as well as a good psychological assessment, and then lead to therapy. And therapy is something that you need to look at whether the person who is providing therapy is actually doing therapy. Actually, they are trained to do those kind of theory-driven therapies. Sometimes therapy can be a chit chat, which is not going to, bring much change.
Right.
But even that kind of relationship can change provided it is done in a way where it's a safe space to explore themselves. It is given in a very kind of a setting where they don't give advice, they don't instruct the other person to do what, but they allow the person to find solutions. So psychiatrists who are trained in psychotherapy is a good choice, or a physician referring to a clinical psychologist, another good choice. So it can work in different, different kind of referral pathways.
So, as you very rightly mentioned, I see a lot of patients with back pain. But when I interact with them, I see that many of the back pains are more of an emotional quotient. So, what would be your advice to me? If I know a good clinical psychologist is the person I should refer to, or should I first, as you mentioned, a psychiatrist to clear out the other causes?
I would say that it can be a clinical psychologist or a psychiatrist, provided they are doing a good job. A good clinical psychologist would definitely look at other factors, and that would also bring change to the patient. But if you are suspecting kind of depression in this patient, or medications are causing sometimes the problems, or medication might be leading to this problem, or medications are needed for the problems, then definitely a psychiatrist would be the initial port of call, and then then work with a clinical psychologist as well.
Right. Because my normal routine of practice is I always refer it to a psychiatrist first, because I really don't know how much our psychologists are actually trained enough, because they might do a course of 2 years and have or a practice, but maybe a trained psychiatrist always has a team of psychologists with him. So maybe I would prefer sending it to a psychiatrist in India. UK could be different. But in my profession, I would always refer to a psychiatrist first.
Our practice it in mind is anybody asking for a consultation first is seen by our resident psychologist, and that is for a comprehensive life history and assessment.
I see.
And they do a detailed 1 or 2 hour assessment, and from them we will as a team decide whether the person fits into just purely by clinical psychologist or first by the psychiatrist. And we always make sure that even a patient who is being regularly seen by a clinical psychologist, if there is any kind of factors like a risk factor, physical health problems, etc., definitely go to the psychiatrist. So when there is a team, it's a safe way to manage things.
Right. What is the scope in the future, apart from all the other medical professions, choosing psychiatry as a career in the next couple of years? Your advice on choosing the career, and what does any MBBS or a medical student need to know to choose psychiatry as a career?
I would want more and more young doctors to join psychiatry, because we need more psychiatrists in India. We need more mental health professionals in India. Worldwide, we need more psychiatrists. So I would encourage anybody to join psychiatry purely because there is a need. Second would it be an interesting job? The more we know about brain, or the more we understand our limitations of knowledge, it is becoming more interesting. The new kinds of investigations, new technologies, and new technologies that is helping us to read human mind.
Right.
The link between technology, computer technology, and the neuronal function. We are reaching a stage where we can actually, using technology, read others' mind, almost there. And the AI is enhancing that ability immensely. So there is much more interesting area where mind and brain, we will see that they are one, and body and mind are one. So it's an interesting phase in the science, and there is more of psychological and psychotherapeutic approaches coming, and more people are realizing that their life could be much, much better if they understand themselves better. And to give that understanding, psychiatry has much to offer. So there is a need, and the field is interesting, field is changing, and people are more and more seeking it. They are accepting it. So it could be a rewarding profession. But I have to warn one thing. It is about what is motivating you. You need to think about that. If you are looking for immediate gratification, you are perhaps in the wrong profession, because working with individuals can be painful, can be difficult, and especially at the one end where you are dealing with individuals who are much more in disorder, aggression, violence, suicidal, self-harming, those kind of self-neglecting. Those are the situations where you need to have an ability to live with uncertainty, ability to be out of your comfort zone, ability to accept that I am helpless here, but I will someday make this person back to where they want to be.
Right.
So it's a long journey sometimes. So you need to be prepared for the long journey as well.
So after this very informative discussion where we had a lot of varied topics talking about mental health of doctors, how we could actually inculcate small habits among parents to improve their children's future. So I think there is a lot more to come. There is a lot more scope for psychiatry, and we all need to focus a lot on our not only physical health, also on our mental and emotional health for a better living. So I sincerely thank you, Dr. Manoj Kumar, for coming all the way from UK just to attend our podcast. And I wish you and your institute in mind all the success for the future, and bring out more courses and interactive sessions for parents, children, and doctors of the medical fraternity.
Thank you. Thank you. And one last word would be, there is a course by the name SPOT,
Okay.
Suicide Prevention Online Training. It's a course done by Institute for Mind and Brain in Cambridge University. It's a free course. It is available in English and Malayalam, and that takes the person through the how to identify distress in other people and what are the skills you need, and it gives immense opportunity to practice those skills, and that will give you a certificate, and that will help you to be prepared to help others in distress. And I recommend that course for doctors and healthcare professionals, and that course is endorsed by Indian Psychiatric Society. So please do sport course.
Okay. So how do we avail this?
It's available online. You
Okay.
can use sport.inmind.in.
Okay.
If you search Google sport, you can reach there.
Okay. Is it only for doctors or even does?
No, it's for public. It's
for
general public.
Right. Okay. So with this very positive note, thank you so much, and thank you once again.
Thank you very much. Thank you.
Okay.
Take care.